Good evening, everyone. My name is Maarten Kroes, Clinical Research Manager, and on behalf of Canon, I'm delighted to welcome all of you to our online oncology days. This evening is just the beginning of 5 very exciting days packed with incredible speakers and interesting topics. The first days will be about liver cancer, followed by lung cancer screening, kidney cancer, and we will close our webinars with a session focused on prostate cancer. I really hope you enjoy the days as much as we have enjoyed bringing them together. So tonight, we will start with liver cancer imaging and how CT and MRI have a role to play in the diagnosis and treatment planning. We have 3 great talks lined up and we will have time at the end for a discussion. It gives me great pleasure to introduce our moderator and first speaker of the evening, Dr. Ewout Smit. Dr. Smit is a radiologist at the Radboud University Medical Center in the Netherlands. He's not your typical medical doctor, as he also has a degree in physics and received his PhD in investigating the development of a single acquisition 4D-CT stroke protocol. Currently, he's an abdominal radiologist with a special interest in liver imaging, combined with CT-related research focused on functional CT and dynamic CTA. I also heard he ran the Marathon of Rotterdam last weekend. Hopefully, he recovered completely and is ready for this webinar. Dr. Smit, today's session is yours.
Thank you very much, Maarten. Good evening, ladies and gentlemen. It's a real honor for me to present here tonight at the Liver Cancer Imaging webinar. We have a great program tonight, which I'm very excited about. First, Dr. Benno Sauer will present on liver cancer diagnosis with MRI. And after, Mark Burgmans will present on CT volumetry to plan and evaluate percutaneous treatment of HCC. But first, I would like to discuss with you the current and future role of CT in liver cancer imaging. I work as a radiologist in Nijmegen. And one of the best things about Nijmegen is that we have a great team where we closely collaborate with radiologists, radiographers, and physicists. So first, what is a liver cancer? Well, when we talk about liver cancer, we refer to primary malignant tumors of the liver. The incidence varies between countries, but is about 5 to 10 on every 100,000 people. The most common liver tumor is HCC, hepatocellular carcinoma, accounting for about 70 to 80% of liver cancers. The second is cholangiocarcinoma in about 7 to 10% of cases. And the third is angiosarcoma in about 1%. And other rare types of liver cancer are hepatoblastoma, primary lymphoma, cystadenocarcinoma, or other sarcomas. However, the most common malignancy in the liver are metastases, which are 18 to 40 times more common than primary liver tumors. And of course, there are also a lot of benign liver lesions, and these are much more common than malignant liver lesions. And they occur in about 6% of patients. And the main importance here is that they should not be mistaken for liver cancer. Well, today we will not focus on the appearance of liver lesions, but instead we will focus on the role of CT in liver cancer imaging, on the imaging pathway. Well, I really like CT research, but when I think of liver imaging, liver cancer imaging, I think of MRI. MRI allows us to characterize liver lesions and to visualize the contents of these lesions with parameters such as T-weighted imaging, diffusion-weighted imaging, and contrast series. And Dr. Sauer will talk more on that in a minute. And if we look at the number of liver-specific exams that have been performed in our clinic over the last year, about 80% was MRI. However, if we look at the number of exams that have been performed on abdominal imaging, about 79% was CT. And again, there's an incidental lesion in the liver in about 6% of patients. So it's really important to know which liver lesions are benign and which need further assessment with MRI imaging. So the main roles of MR imaging are in the lesion characterization. What type of lesion are we looking at? And also before local treatment, to assess each and every lesion, for example, before surgery. You want to make sure that there are no additional lesions apart from the ones that you remove. And we also see that there's a huge reduction in the number of biopsies when using MRI. We can define lesions as being certainly benign, ones that are most likely malignant and need surgery, or ones that require follow-up. And we do few liver biopsies in our clinic. But the main roles of CT are in diagnostic imaging, if a patient admits to the hospital with specific symptoms, for staging in oncology, for surveillance, and also for the assessment of treatment response. And advantages of CT are the reasonable cost, the wide availability, the exam-to-exam reproducibility, and the short acquisition times. And of course, a disadvantage is the use of ionizing radiation. So what are the recent advances in CT imaging? Well, one technique that we are very excited about is deep learning reconstruction, which provides us with very good image quality. So what is deep learning reconstruction? Well, in deep learning reconstruction, a model is trained on high quality model-based iterative reconstruction images, which have been processed for days to weeks in the lab. And then a neural network is trained, which we apply in the clinical practice on new scans of new patients. And this provides us with high image quality. And the advantage of such an approach is that it's very time consuming to learn what high quality images look like, but applying it in clinical practice is really fast. Here we see an example of filtered back projection on the left, the previous technique. Hybrid iterative reconstruction, the current most commonly used technique, and on the right, deep learning reconstruction. Well, we see that there's a drastic reduction in the amount of artifacts, for example, in the pelvic region. But also, if we look at the liver, we see the large cyst, but also the smaller cyst alongside it. And we see that it's much sharper demarcated, and therefore we can be more certain that it is a benign lesion. Here's an example of a patient in an obese patient. On the left, we see hybrid iterative reconstruction, current standard, and deep learning reconstruction, the new standard. In this obese patient, we see that there's very good image quality, especially also of the liver. And what we like about deep learning reconstruction is that it provides us with more diagnostic confidence. Lesions are more sharply demarcated, so the contours can be better appreciated, and therefore it gives us more confidence that, for example, a cyst is benign. And also the image quality of the thin section images is high quality, and we often read the thin section images nowadays, and that gives us more confidence about benign lesions, especially in cysts. And here we see an example of liver metastasis. On the left, we see hybrid iterative reconstruction, 3 millimeter sections, and on the right, we see the deep learning reconstruction images. And we see, if we zoom in, that the metastases are better visible, better demarcated, as we can see here, and with a reduction in dose. So how much dose reduction can you get with the new technique? So here on the left, we see the radiation dose of our chest abdominal CT in the 6 months before the introduction of ACE, deep learning reconstruction, and in the 6 months after the introduction of deep learning reconstruction. ACE is the commercial name for deep learning reconstruction. And we see that the radiation dose is about 40%, which is in agreement with publications in literature. So is dose reduction still a priority, you may ask? Well, I do think so, especially with new therapies such as immunotherapy. We see that the survival of patients has drastically improved. For example, on the right, we see an overview of a patient who had over 20 CT scans of the chest and abdomen, and this is getting more common. So therefore, I think that dose reduction is still a priority. So in liver imaging, it's very important to do multi-phase imaging. Here we see an example of a non-contrast scan where a lesion cannot be visualized, the arterial phase where we can clearly see the enhancement, and the venous phase where enhancement gets similar to the liver parenchyma, and in the late phase the liver is difficult to assess. And this is because the liver has a dual blood supply from the portovenous system, which is about 80% of the liver, and the arterial blood supply, which is only about 20%. But for the majority of liver lesions, the blood supply is mainly arterial. So it's important to do multi-phase imaging. And here's an example of a patient with cirrhosis. We see a very lobulated contours of the liver. And in the non-contrast phase, the arterial phase and the venous phase, we cannot appreciate the lesion, despite that most HCCs have strong arterial blood supply. And this HCC was only visible because there was very subtle washout in the late phase, and it was originally missed. It can be assessed from the contours, but the washout is very subtle. However, if we look at the subtraction images on follow-up imaging, we can see here the venous phase, and here the subtraction images, and here the washout becomes much more apparent. So what is subtraction imaging? Well, it's really a simple concept. We have a contrast-enhanced scan, we have a non-contrast-enhanced scan, and these two are then subtracted to get the contrast maps, the iodine maps. But for this, of course, because they're separate scans, we need motion compensation. Well, on the left, we see a 4-phase liver CT, and if we go through time, we see that there's motion from breathing and motion in the diaphragm. But if we go to the right, we can see that there, after motion correction, this motion has been removed from the software. And this allows us to do subtraction imaging over the several phases. So the resulting maps are referred to as iodine mapping. On the left, we see an iodine map resulting from subtraction imaging. And on the right, we see an iodine map which has been processed with dual energy imaging. And both techniques can be used to obtain iodine mapping. Well, in our clinic, we have both techniques available, but we prefer subtraction imaging because it's a very simple technique. And also because the subtraction images are iodine only. As I explained, we have the contrast series minus the non-contrast series, so the result is iodine only. But if we look at the dual energy images, the water is removed, so this is iodine plus calcium. An advantage of dual energy is that it provides us with low KEV imaging, where you can increase the contrast. And as you can see here in this same lesion, we see that it's slightly better visible on low KEV imaging. But a disadvantage that we often see is that it also introduces the artifacts. So sometimes lesions are better visible, but you also have more lesions that you're not sure about, or artifacts that may be mistaken for a lesion. As we can also see here. In this lesion, it's better visible, but also artifacts are introduced. So besides these recent advantages, what could be a future role for CT imaging? Well, I think the future is in functional imaging. Here we see an example of a HCC that has been treated with immunotherapy. On the left top, we see the scan at admission. Here we see after 5 months follow-up, the lesion is getting smaller, but also we get these cystic components. And after 8 months, we clearly see that there is a cystic degeneration of the lesion. And after 12 months, this is increasing. So we have a completely different treatment response from the previous therapies. So we have now cystic degeneration. But the disadvantage of these immunotherapies is that they're very expensive. So if we can predict if there's treatment response in an early phase, we may earlier know if this treatment needs to be proceeded. And if we look here at the subtraction images again, we see here that this lesion has cystic degeneration, but that there's still enhancing components. So there's still viable tumor. And this may allow us to do a treatment response prediction. And here we see the same patient in 3 directions. And you can also see that there's excellent registration of the images, and there's There's no motion visible in the diaphragm. Another thing our group focuses on is dynamic CT, where we try to quantify the amount of enhancement in a lesion. Well, if you do dynamic CT scanning, the individual images have to be acquired with low radiation dose, and therefore they are of low image quality. So if we look at a typical exam, we see here over time that there's contrast enhancement and there's parenchymal enhancement, but the images are of poor quality. And if we use similarity filtering, a technique that has been developed in our clinic and that is available in brain and in cardiac imaging in the Vitreya software, we see that the image quality is drastically improved. On the right, we see the same image, but after noise reduction. We see the arterial blood supply, the portovenous blood supply, the enhancement of the liver parenchyma, and we are investigating if this may improve diagnostic workup. For example, a focus of research is that we can maybe do a dynamic CT at the radiation dose of a current 4-phase liver CT. On the top, we see a phantom with a 4-phase liver CT radiation dose. And on the right, we see the result after filtering. And on the bottom row, we see the same, you see the scan with dynamic CT, 1 phase, and after filtering. And we see that the image quality is of similar quality. So that's something we are investigating at the moment. And for example, that may help in treatment response prediction. If we look here in this lesion, we see if we look over time, that we can be confident that there's no contrast enhancement in this lesion. But if we look here at this lesion, we see that there's progressive contrast filling, so there's still viable tumor in this metastasis. So to summarize, the role of CT in liver cancer imaging is to differentiate liver cancer from benign liver tumors. MRI is excellent for liver lesion characterization and before surgery to assess each and every lesion. But CT is very helpful in the diagnosis, staging, and follow-up. We discussed deep learning reconstruction, which improves diagnostic confidence and helps in dose reduction. We discussed IDA mapping, which sometimes makes it easier to see lesions, and this can be performed both using geoenergy imaging and subtraction imaging. And the focus of these techniques mainly is in the reduction of the need of additional MRI. If we can be confident that this is a benign lesion, we may not need additional MRI. And the future, maybe in functional CT for the assessment of treatment response prediction. Thank you very much for your attention. So now Dr. Benoît Sauer will present on MR imaging of the liver. Dr. Sauer is a radiologist from France in the city of Strasbourg, and he will talk about MRI imaging of the liver. The floor is yours.
Thank you for introducing me. Let's speak about MRI. I'm Dr. Sauer. I work in France in the group MIM in the Clinique Sainte-Anne. I just speak about liver diagnosis with MRI. What is the place of MRI? MRI becomes the gold standard for liver evaluation, as said Dr. Smith. It's a non-irradiant imaging. It's better for characterization after making an ultrasound or a CT scan. And there is rising indications in follow-up. Which lesion? The first rule of MRI is exclude benign lesion with MRI. The majority of lesions are metastasis, as shown before, but also there is primary liver cancer like cholangiocarcinoma or HCC. Rising indication and quality. There is an increase of the number of the requests by clinicians due to the aging of the population and increasing of number of cancer. Also, there is a better survival after treatment and necessity of close checks on different treatment like radiofrequency, immunotherapy, and other things. Also, more examination in different conditions because we are more fragile patients, so elderly patients, obese patients, which are a problem for quality imaging. So what is our standard protocol? In fact, our standard protocol is very easy. It's T2, T1, gadolinium, DWRI, the diffusion weighted, but we use a lot of DLR. What is DLR? Is the deep learning reconstruction. In Canon, that's ACE, and for other constructors, there is another name. And this DLR permits us to make more things, more quality, and lots of sequences are on Breezel, the majority. Only diffusion weighted is not on Breezel. So what is important is to gain quality and to decrease the time of sequences. The technologies are very, very important. It's essential. It's essential to optimize the MRI protocols with the application specialist, but also for explain to the patient, the instruction should be really be understood by patients, and follow the examination and verify the images and repeat the instruction if necessary. And be careful about the difference in the position of the lever between breathe hold and free breathing. And so that's more important in different conditions. So for elderly patients, we can have a problem with comprehension or deafness. The use of headphones in MRI to understand the instruction is very important, and sometimes use visual signal. And obesity is a problem with hepatomegaly. It's important to choose the right slice thickness or a coronal evaluation. The order of sequences is basic. It's an anatomical review in T1 and T2 in results. With DLR, each sequence lasts 20 seconds at maximum. It's a compromise between spatial resolution and duration. We don't use lots of T2 with gating because for stress patient, with respiration is irregular, and so it doesn't work everywhere very well at each time. Anatomical anatomical analysis of the liver is the first part. Sign of cirrhosis is an orientation to the HCC. Steatosis is also important with T1 Dixon. And after the analysis of the liver is the pattern of the lesion. What is evident is the pattern of the lesion. Hyper-T2 like CSF, it's classically angioma or cyst, but be very careful for mucoid or necrotic lesion. The pattern of lesion of a slight hyper-T2 is an indication for malignant lesion. ISO-T2 are commonly focal nodular hyperplasia or adenoma, but also could be metastasis or HCC. Injection of gadolinium, we use gadobopta, which allows us to make an hepatobiliary phase in some cases. It's a problem with the quality of apnea. The challenge is to save time. Each sequence before DLR durate 20 seconds, but yet with DLR it's 13 seconds, and even with we have a protocol of 9 seconds. It's a compromise between slice thickness, quality, and duration. It's very important for elderly patients. Washing, the classical in focal nodular hyperplasia, it's the evaluation in the arterial phase with a lesion and ISO-T2 and great washing. And the washout is very important for HCC, especially in hepatobiliary phase. But the hepatobiliary phase is made at 20 minutes. We don't use it. Why? A recent multi-center study showed there is no difference between the extracellular phase, quite 7 minutes, and the hepatobiliary phase of 20 minutes. But it's the gold standard in LIRADS for HCC. Diffusion weighted imaging, I think it's present and the future of MRI. It's the concept of cellularity. There is no need of injection. It permits early detection and follow-up of the lesion. The question is ADC. We don't use the value of ADC because there is an overlap between a benign and malignant lesion. And we use diffusion weighted imaging after injection. In fact, it doesn't change anything. For some article, there is a quite difference on ADC, but not on the pattern of the lesion. Which be used? in our center, we use two diffusion. One is the B800 and another is the B1500. But increasing B is a problem because it increases the specificity, but need more time. It could be a problem. Some clinical example. I want to show our daily practice with our routine protocol of less than 10 minutes. I work in a medical surgical clinic with chemotherapy, radiotherapy, surgery. I just want to show real cases, real life cases of the last 3 months, and different patterns should be known because that's not so always evident in MRI. First, a woman of 50 years without specific history. A sonography showed an heterogeneous and hyperechogenic mass. It's a hyper-ADC, hyperdiffusion. There is a rim of enhancement on arterial phase and a complete filling, but the rim is complete. It's a problem because for non-angioma, it should be discontinuous. We control this patient 1 month later with a better arterial phase, and the arterial rim enhancement is discontinuous. It was typically an angioma. That's the first rule of MRI to show that the lesion is benign. Another case, a woman of 33 years, typically an ISO T2 with a great wash-in and no washout, an equilibrium on portal vein. It's typically with the central scar, hyperplasia, focal nodular hyperplasia. But that's for introduce the future case. Another woman, 36 years, an hepatic mass on sonography, a solid mass with a central scar, but she had weight loss. And so when we make the MRI, it's totally different. The lesion is slight hyper-T2 or quite strongly hyper-T2, heterogeneous with an indirect sign of malignancy, the biliary duct dilatation. It's hyper-diffusion, and what is interesting, it's a hyper-ADC. As you see, the value of ADC is not always valuable. When we make the injection, it's a necrotic, and you can see also the cancer of the left angle of the colon. It's a mucoid form of colonic cancer, typically malignant. Also case, a woman of 83 years, follow-up of melanoma, a PET-CT with a slight take of FDG, hyper-T2, quite a CSF, could be doubtful. When we make the injections, quite no injection. It's difficult to see, but the diffusion is very interesting because we have a real hyperdiffusion with a low ADC. In this case, the ADC is valuable, and it was a metastasis of melanoma. Other case, a man of 82 years, extension of colonic cancer. Pay always attention to the biliary duct on T2 with a dilatation, but the lesion is ISO T2, but on other sequences like injection or diffusion, the lesion is typically malignant. Other case, another man of 78 years. There is a discussion between the fat saturation of fat on T2. I don't use very much this sequence due potentially to artifacts. This lesion is very interesting because there is an enhancement of a peripheral rim on arterial and portal vein, but no enhancement of the center. And we make the diffusion. There is only cellularity on the margin. That's necrotic. And if you see the T2, that's not always in hyper-T2. That's quite ISO-T2 or slight hyper-T2. It's possible with necrotic lesion. Another man, 65 years, an hepatic mass around the gallbladder with invasion of the ileum. It's a cholangiocarcinoma. This case is also interesting because the patient was very altered, And we use shorter sequence with DLR in dynamic injection, quite no loss of quality, but we have the information in only 13 seconds each phase. The rising indication is a follow-up in MRI. Typically a colon cancer, we make the MRI, the lesion decrease with chemotherapy, more visible in diffusion. In some cases, it's not so evident. For example, this woman of 66 years with a breast cancer, the margin of the lesion are not so visible on T2, but on other sequences, and especially diffusion, it's better. And sometimes, as you see, with injection, it's not so evident, the margin. But with RECIST, it's important to measure correctly the lesion. And in most cases, especially for breast cancer, the DWI, the diffusion is very important. Another case, a woman of 70 years with a colon cancer, slight hyper-T2, hypovascular, but in diffusion malignant. She benefited from a radiant frequency. The lesion remained hypovascular, that's normal, but in diffusion, the lesion disappeared. It's a success of radiofrequency. Other case, a woman of 46 years, follow-up of colon cancer, before and after chemotherapy, there is a response, but partial. She benefited from radiofrequency and surgery. What is interesting, you can see the lesion, there is an hypovascularity, but in diffusion, be aware, all what is white is not malignant. As you see that there is a T2 shrining, you can use IDC or either the T2 to see that. Other case, as shown Dr. Smith before, for HCC, that's not always so evident. There is a typical cirrhosis. And in this case, the washing, it's not evident. The diffusion is evident, and the washout is also evident. Also, what is interesting in this case, this washout is really visible in extracellular phase. In most of cases, we don't need the hepatobiliary phase of 20 minutes. It's a great gain of time. What is important also is to see the surrounding. Here you have an HCC of the whole left lobe. But if you see the vertebra, you can see also little spots, which is a metastasis as shown on the CT scan. Okay, for concluding, time is quality and comfort. Our standard protocol lasts in total less than 10 minutes, installation included of the patient. But with the increase of the breath hold, optimization is necessary. It's important that the patient understand clearly the instruction. The deep learning allows us a shorter examination time, more comfortable for the patient with an improve of the image quality. And some specific patterns should be known. So 3 take-home messages: having a robust and rapid protocol, well known by technologists, and the follow-up and the check of the image examination by the technologist is crucial. And the technologist should adapt the protocol with rapid sequences for altered patients. Thank you for your attention.
Thank you, Dr. Sauer. It was a really nice presentation. I learned a lot from also the beautiful cases. So the questions will be afterwards. We will continue this session with the presentation of Dr. Burgmans. Mark Burgmans is an interventional radiologist in Leiden, the Netherlands. He is specialized in image-guided, minimal invasive image-guided treatment of the liver, especially in oncology. And his presentation will be now. The floor is yours.
Well, thank you very much, Ewout, and thank you, Canon, for inviting me to speak on the first day of the Canon online webinars. Tomorrow there's a whole session dedicated to the treatment of liver cancer. So I think my talk will be sort of a bridge between liver imaging and liver treatment. As I've already mentioned, I'm an interventional radiologist, and I'm working in the Leiden University Medical Center. But for us as interventional radiologists, of course, imaging is of utmost importance. So I will now discuss with you the use of CT volumetry when planning and treating HCC, and in particular in the treatment of early stage HCC. This is my disclaimer. Well, Ewout already mentioned that hepatocellular carcinoma is the most common primary liver tumor that we know. It's the 5th most common cancer type and the 2nd most common cause of cancer-related death. It's most common in sub-Saharan Africa and Southeast Asia, but also in Western countries, the incidence is rising. And even in those countries where they have all the various treatment options available, the prognosis is poor, with a 5-year survival of around 15%. Now, in Europe, this is the most commonly used staging system, that of the Barcelona Clinic of Liver Cancer. They recently published an update, the 2022 update. Well, it's a fairly complex figure, but let's just zoom in on the left part of the figure. And there you will find the early stages of disease. And for those stages, we recognized 3 different curative options. And those are ablation, resection, and liver transplantation. And if these curative options are not feasible, then transarterial therapies can be considered. And we recognize 2 different transarterial therapies, and those are transarterial chemoembolization and radioembolization. And according to the guideline, these are considered equally effective. Now, in all these different treatments, we often use CT volumetry, and there are different software packages available. We commonly use the Canon Vitrea system to do our CT volumetric analysis. That's a fairly simple software package that allows automatic registration. With just a few clicks, you usually get volumes of liver and tumors, as well as segments that you think should be resected. Now, so let's first look at the application in liver surgery. So I mentioned resection is a curative treatment option, and there are different major resections feasible in patients with HCC. Those can be seen in the figure: right hepatectomy, left hepatectomy, the extended right hepatectomy, and extended left hepatectomy. And for all of these, it's important that the part of the liver that's left behind is sufficient for the patient to remain sufficient liver function. That is an issue in patients with HCC because most of these patients have underlying liver disease, so their liver function is already compromised. Now, as a rule of thumb, we usually say that patients with a normal liver parenchyma, should at least have a liver remnant after resection of more than 30% of the total liver volume. For patients with cirrhosis or fibrosis, the FLR, future liver remnant, should be bigger, at least 40%. And of course, for some patients with severe cirrhosis, and in particular those with portal hypertension, a resection is not feasible at all. Now, we can also add functional information to our volumetric analysis, and functional information could be indocyanine green clearance test or technetium-99 mebufotenin SPECT-CT, but I won't go into too much detail on those. So if we have a patient that has insufficient liver volume, what we as interventional radiologists can do is a portal vein embolization. That involves placement of a catheter using a transhepatic approach. We place the catheter into the portal vein, and then we embolize part of the portal venous system, usually with glue. Now here's an example, a 67-year-old male, 2 lesions in the right liver lobe, 1 large lesion in segment 5 and a smaller lesion in segment 7. And using the Vitreous system, we calculated the potential FLR. So the FLR is indicated in green. That's the part of the liver that would be left behind if you perform a right hepatectomy. The red part is the part that is going to be resected. And it turned out that the FLR was estimated to be 29. So that is too low. So we performed portal vein embolization. On the left, you can see the images before the embolization. A catheter has been placed in the left portovenous system, and you see a portogram with the different portal vein branches. Now on the right, you can see the images after the embolization. You see a glue cast in the right portovenous system, as well as several coils. Now, what happens after the portal vein embolization, you see that there is hypertrophy of the left liver lobe. You can clearly see that the left liver lobe is now extending more to the left side and is hanging over the stomach. And if you calculate the FLR, it now turned out to be 39, so that was sufficient to perform the right hemihepatectomy. And this is after a resection. You can see that there is a further increase of the volume of the left liver lobe, and this patient recovered without any issues. Now, let's look at the second curative treatment option for early stage ACC, and that is thermal ablation. The most commonly used techniques are radiofrequency ablation and microwave ablation. Both are fairly similar. We place a needle into the tumor and we use thermal energy to coagulate the tumor. Now, according to the European guidelines on HCC treatment, thermal ablation is the treatment of choice for small lesions, lesions smaller than 2 centimeters. But in larger lesions, the resection is still regarded as the first-line therapy. And this is because the local recurrence rates after ablation are slightly higher than after resection in lesions that are larger than 2 centimeters. So local recurrence rate after thermal ablation are slightly higher than after resection, but ablation has much lower complication and morbidity rates, lower cost, and patients usually recover faster. So for the future, what we really want is to improve the results of thermal ablation and thus make it as effective as resection. And then we have a treatment option that is as effective, but safer and cheaper. So let's look at the causes of local recurrence after thermal ablation. As I mentioned, we place a needle into a tumor and then we apply thermal energy. Now, the temperatures that we achieve are usually highest close to the needle, and then with thermal conductivity, the heat is propagated to the periphery of the tumor. And the temperatures at the periphery of the tumor are usually lower as compared to those close to the needle. So as a result, we may end up with an area at the periphery of the tumor where the temperature is insufficiently high to cause tumor necrosis. So tumor cells may stay behind vital tumor cells and thus cause recurrence. Furthermore, in HCC, we often see that there are satellite nodules. So those may not be visible on your CT or MRI, but we know that there might be microscopic satellite lesions in close proximity to the main tumor. That occurs in quite a high number of patients with HCC. So those two areas in yellow you see could be a cause of local tumor recurrence. Now, to prevent that, we usually try to ablate with a safety margin. We try to ablate the tumor with at least a margin of 5 millimeters and preferably a wider margin. Now, in the ideal world, the ablation is nice and round, but in reality, the ablation may be deformed as a result of tissue factors such as heterogeneity of the tumor, the presence or absence of a tumor capsule, fibrosis or cirrhosis of the liver parenchyma, and the so-called heat sink effect, which is a cooling effect of larger vessels within the liver. So if you have a deformation of the ablation zone, you may end up with areas where there is insufficient heating of tumor cells and thus recurrence. Now, currently, we assess ablation margins with eyeballing. So we have a CT or MR that was acquired prior to the intervention, and we compare that with the CT or MR that is acquired immediately after the ablation. And then we have juxtapositioning of the two cross-sectional images, and we estimate the ablation margin with eyeballing. Now, that is fairly inaccurate. And what we are now using is the fusion imaging of pre and post-procedural images. So you can merge the pre-procedural CT with the post-procedural CT and then perform 3D quantitative margin assessment. You see an example of that here. These are two CTs projected over each other, and with software we can now three-dimensionally quantify the ablation margins, and in column mapping it is indicated where you have the lowest obtained margins. This is something that is still under investigation because currently it is not very well known what the exact correlation is between ablation margins and recurrence. So if we have a patient with an ablation margin of 3 millimeters, how high is the risk of recurrence in that individual patient? This is still something that is unknown, and therefore we are currently conducting a large prospective study in the Netherlands, the Prometheus study, in which all patients that undergo thermal ablation for HCC have a pre and post-procedural CT during the intervention. So the patients are put under general anesthesia. We perform a CT scan, do the ablation, and immediately after the ablation, we repeat this CT scan. And these scans are used to do the three-dimensional margin assessment. And from that study, we probably get the information that will tell us the exact correlation between minimally ablation margins and local recurrence. Now let's look at the alternative treatments, the transarterial treatments. So if there are curative treatment options, it being resection or ablation is not feasible, we could then perform transarterial therapies. And one of those is selective internal radiation therapy. This is also called radioembolization. And what we do is we inject multiple microspheres, and those microspheres are loaded with a radioactive substance, usually yttrium-90 or holmium-166, and this can then cause local intense radiation therapy. So that's an alternative for external beam radiation therapy. We can do this because there is, as you are well aware, a difference in the vascular supply of the liver parenchyma and a tumor. The liver is mainly supplied by the portal venous system, whereas liver tumors, particularly HCCs, receive almost all of their blood through the hepatic artery. So the HCCs are usually supplied by the hepatic artery for 90 to 100%. Now, as interventional radiologists, we are well known with the vascular anatomy of the liver. As you know, there are 8 segments in the liver, and these all have their individual artery. So these are the 8 segmental arteries that we can visualize using angiography, and we can then catheterize the segmental artery of the tumor-bearing segment. Now, Canon has a great system, which is the combination of angio and CT. So that allows you to perform angiography and combine it with CT. And you can perform CTs while you are injecting contrast into the segmental artery. So on the right, you can see opacification of segment 3. So the segment 3 artery was catheterized, and then we performed the CT with selective contrast injection. And second, we can then inject microspheres into that segment, and those microspheres will lodge in the endarterioles of a tumor and cause intense local radiation therapy. Now, that's a principle that we call radiation segmentectomy, because you really give a very high dose that would cause severe radiation to the entire segment and eventually atrophy of that particular segment. Here's an example: a 75-year-old male with a NASH cirrhosis. He was not a candidate for ablation because the tumor is too large, it's almost 5 centimeters. Not a candidate for resection because of cardiomyopathy. So we performed a transarterial therapy, a radiation segmentectomy. Here you can see the CT with the hypervascular tumor, and in the venous face, you can see the washout as well as invasion of a segmental portal vein. Now, these are the angiography images where we have catheterized the tumor feeding artery, the segment 8 artery. We confirmed that we are in a correct location using cone beam CT in this particular case. And then as the last step, we need to calculate the dose that we need to give. This is a fairly complex formula, but as you can see, it has the word volume in there. So we need to do volumetry to determine which dose we are going to use. And again, we can perform volumetry with the Canon Vitreous system, determine the volume of the entire liver, as well as the treatment area and tumor to calculate the dose. And these are the images that are obtained after treatment, SPECT images that show that there is a very intense uptake of the radionuclide in the tumor while sparing the rest of the liver. And this then causes tumor necrosis. This is the follow-up CT after 3 months, where you see complete tumor necrosis and also necrosis of the portal vein invasion. So this brings me to my last slide. I hope I've shown you that CT volumetry is very useful in the treatment of HCC. It allows individualized treatment planning when performing interventions. Canon Vitrea is a system that works very well for these purposes with semi-automatic segmentation of the liver and liver tumors. We use it to calculate the FLR in patients undergoing liver resection and portal vein embolization. Quantitative analysis of margins after liver tumor ablation is a very promising tool that I think we will use very frequently in the future, but something that is still under investigation. And we use volumetric analysis to do dose calculations in patients undergoing SIRT. And with that, I come to the end of my talk. Thank you very much for your attention.
Thank you very much, Mark. It's a really impressive presentation. I really feel that's the future of radiology. So now we will head to the Q&A. Some questions have been addressed. Dr. Sauer, Benoit is also online again, I see. Well, we have several questions. I'll present them in random order. So one question is, what do you prefer, CT or MRI for the follow-up of HCC in terms of modified races, for example? Benoit?
For me, that's MRI, because the use of diffusion. As I said, the diffusion is the present and the future of MRI. Using this sequence is very, very important. So you can see, as you show on CT, the necrosis, the cellularity. You have the information of enhancement in the same examination.
Yeah. Do you want to comment on that, Mark?
Well, I fully agree. I think MR gives you the most detailed information, in particular after local therapy. For example, after thermal ablation, I think MR is superior to CT. For some other treatments where you really have palliative treatments, it may not be that important, and CT gives you the advantage that you're also able to screen the rest of the body, of course, including the thorax and rest of the abdomen. So for patients that receive palliative treatment, I think CT is a good option, but if it's still local disease contained to the liver, I would definitely prefer MRI.
Yeah, I also agree with you both. Also in metastatic disease, we tend to prefer CT, and sometimes we're a bit pragmatic in terms of using CT if the lesion is easily visible, and it's mainly because of limitations in the availability of MR imaging, despite being more precise and a better technique. Okay. Question to you, I think, Benoit. So the question is, in follow-up of a specific liver lesion, do you adapt the protocol? So do you use a full protocol in the initial scan, and then follow-up imaging? Do you adapt the protocol to the most relevant sequences, or do you tend to use the whole protocol again?
It depends on the cases. Most of the case, we make the full protocol, especially when there is a focal lesion, as said our colleague before. It's interesting to see a satellite nodule or something else. But for other cases, like with carcinosis or in a palliative case, we only make the most visible sequences. And what is interesting also, we make a whole abdomen evaluation in diffusion. It's very interesting because in less of 10 minutes, you make a diffusion of the liver and a diffusion of the pelvis. And we have the whole exploration. It's interesting for seeing nodules of carcinosis, sometimes primary lesion of the colon, or when the patient wasn't operated. So there is an adaptation of the protocol depending on the case in the follow-up, but quite always the diffusion.
And do you adapt the protocol on beforehand, or if the patient is on the table? Do you?
No. On the table, if we let the protocol, it's before. It's easier for us because we are a big center of oncology. We know the patient.
Yeah.
So we have the formal examination. And if we don't have the whole examination of a patient before our examination, we make the whole protocol, always.
Great, thank you. A question, I think, related to my presentation, because it was addressed at that time point. At what time is the late phase acquired? We scan at about 3 minutes post-injection for the late phase. For the arterial phase, it's 24 seconds after bolus tracking in the aorta. And the venous phase is about 40 seconds after the arterial phase. And what I find most important is that the arterial phase is a late arterial phase. So there is already enhancement of the liver lesions. We sometimes see scans from other centers which are scanned in the early arterial phase, and then liver lesions may not be visible. So it's important that there's already some enhancement in the portal vein. For cholangiocarcinomas, we sometimes scan a bit later, an extra additional phase, but it doesn't really happen that often because then we focus on MRI. Okay, for Mark, the question is, how soon do you do ablation, CT follow-up after ablation? The person asking is doing that at 4 to 6 weeks after ablation. What's your recommendation?
Yeah, so we always do a CT scan immediately after the ablation. So all the ablations are done in the CT room, and all patients will get a CT immediately after the ablation while they're still under general anesthesia. So we are sure that if the patients go off the table, then we have a technical success. Then the next follow-up scan, MR is usually done about 3 months later. So I think it's also okay to do your first follow-up scan earlier, but if you have done your CT immediately after the ablation, I think you're pretty confident that you will not have early recurrence or residual disease, and a scan 4 to 6 weeks after the thermal ablation might be too early to spot a recurrence. But I think in this case, there is no right or wrong. I think there are different options. So,
okay, thank you. And another question related to that, Mark, is what do you think about the role of CT after stereotactic radiotherapy?
It's a difficult one. It's actually a scan with which I often struggle. I shouldn't say often, because first thing, of course, is that stereotactic radiation therapy is usually not considered the first-line therapy for HCC nor for liver metastasis. Usually resection and ablation are considered the first-line therapies, and stereotactic beam radiation therapy is an alternative. So probably the numbers of patients that undergo SBRT are not that high. They are not that high in our center, but we do occasionally see them. And I often find those scans pretty difficult to interpret, especially early after the SBRT. You may occasionally think there still is a residual tumor, but the radiation therapy needs time to kick in, I would say. So you really need to give it some time before you can actually say this is progression or not. I don't know what you feel. Maybe you have more experience on follow-up on SBRT than I do.
No, I fully agree with you. In ablation, you really make the zone dead. You have necrosis, and in radiotherapy, it's much more delayed effect. And that makes the follow-up imaging rather difficult. I agree with you. And we don't do it that often. I must say that we are pretty pragmatic in the multidisciplinary team on which techniques we decide. And so we often do stereotactic radiotherapy. And then we just do follow-up imaging, for example, after 3 months or so. Yeah. There's a question on the contrast agent, gadolinium bobta, multi-hands. The biliary phase is about 2 hours. And the question asking is gadolinium DTPA, which saves about 7 minutes. Why do you prefer for multi-hands? Why do you prefer multi-hands?
In fact, the hepatobiliary phase begins at 20 minutes. Really, a lot of people make 1 hour or 2 hours, but for organization, it's very, very complicated. If you take the LIRADS, which is a reference, it's a make for 20 minutes. But as I said, the hepatobiliary in the recent multicentric study don't show is not better than the extracellular phase. But there is also a question about this extracellular phase. What is the time? 7, 8, 10 minutes? It's not so evident. For us, the time of extracellular phase is depending of the time of diffusion. I'll explain, because we begin the injection with the arterial phase and portal phase, and so we make the diffusion weighted imaging. When we have the B1500, it's longer with a gating. It can the sequence can durate up to 6 minutes. So it will be 8 minutes for the extracellular phase, or even with the B800, 6 or 7 minutes.
Thank you. Yeah, that's very interesting. And do you use for the diffusion weighted imaging also image registration for the ADC labs?
Image registration, what do you mean?
So there may be some motion between the B phases, and then the calculation of the ADC values may be challenging. And we see a huge variability in the image quality of the ADC maps as we are referring centers. So I was wondering.
Yes, I'm for the ADC maps, we don't use it. In fact, I'm very, very, or say that in English, I don't, the value are not valuable for me, the absolute value of ADC.
Yeah.
So because the overlapping of the lesion, as I show, that's why I wanted to present my first case with a mycoid cancer. It was hyper ADC. It shows well the problem of ADC.
Yeah. Great. I'm really sorry, but we're heading out of time. So we have one last question. The question, yeah, there are several questions on contrast-enhanced ultrasound. We focused on CT and MR and post therapy. So I'd like to finish with contrast-enhanced ultrasound. We didn't include that. Do you use that in your clinics?
Yes.
Benoit?
Yes, lots. It's very interesting, especially for benign lesion and follow-up when you have big focal nodular hyperplasia. It could be interesting also after radiofrequency and in some cases to see better the margin or focal hyperarterialization in HTC.
And you, Mark, do you use it?
We do use it. Yeah, we usually use it for planning as well. If you have a cirrhotic liver, it can be really difficult to distinguish an HCC from other nodules like regeneration nodules. So if you then use contrast-enhanced ultrasound, you will see your HCC as a bright spot, and that will allow you to recognize it and to be sure that where your HCC is, and determine whether or not you can target it. For follow-up, I find it a bit more difficult because it allows you to zoom in a certain region, but it's more difficult to see other regions of the liver. And of course, we know that patients with an HCC are at an extremely high risk of developing new HCCs. So you really want to see the entire liver if you're doing follow-up.
Yeah, to finalize for our clinic, we do not use it despite being a very promising technique, and I've seen great results in literature. But the main reason is that it's not reimbursed in the Netherlands. probably also for your clinic. So we consider it, too expensive and too time consuming, unfortunately. With that, there are many other questions, but I'm sorry we have to close our session because of the time. I would like to thank everybody for their attention. Also, Mark and Benoit for your excellent presentations. And I really enjoyed this evening. So I'll give the word back to Mark.
Thank you, Dr. Smith. That brings us to the end of day one. I'd like to thank again our speakers and moderator, Dr. Benoit Sauer, Dr. Mark Burgmans, and Dr. Ewout Smit for kicking off our oncology days. Great presentations and a really interesting discussion. I hope to see you all again tomorrow evening at the same time when we have a great lineup of speakers ready to share their experience and expertise in image-guided treatment for liver cancer. Thank you all for joining and hopefully see you tomorrow. Bye.